10, AKI, and renal replacement therapy. We're going to talk about timing, dose, fluid strategy, crystalloid choice, bedside tools, clinical framework. First paper is AKIKI, delayed RRT strategies, severe AKI. So basically, we looked at K-DIGO, stage 3, severe AKI on mechanical ventilation or vasopressors, French ICU, 60-day follow-up. We're looking at early RRT is 48.5 mortality, delayed only for absolute indications. That would be AEIOU, which is acidosis, electrolytes, intoxication, uremia. That would be 49.7% mortality. And the point is that half of the severe AKI patients recover spontaneously when you just wait. There were more infections in the catheter group, early catheter placement, early complications, absolute indications. When do you start RRT is when there's oliguria for greater than 72 hours, a BUN greater than 112, potassium greater than 6, pH less than 7.15, but we went over that AEIOU. What does it mean, watchful waiting? Doesn't mean nothing. It means treat the underlying cause, optimize hemodynamics, and avoid nephrotoxins. AKIKI 2, which we'll look at in paper number 5, defines the limit, but watchful waiting wins. Early routine RRT severe AKI does not reduce mortality. This was a 620 patient French ICU trial, New England Journal of Medicine, 2016, but 50% of delayed patients never even needed RRT. The ELAIN trial is paper number 2 in JAMA the same year. It was a single center ICU Germany, 231 patients. This was the only one that showed early RRT actually benefited. So the early RRT within 8 hours, K-DIGO 2 showed 39% mortality, whereas delayed RRT showed a 54.7% 90-day mortality. It is not generalizable. 85% were post-cardiac surgery, so it's very different than a medical ICU. And the renal recovery, early RRT showed better renal recovery. Why does it differ from every other trial? It's a single center. This team was expert in early CRRT implementation. Surgical ICU population is very different. The NGAL biomarker selection enriched for true AKI, and the sample size was too small to be definitive. So this is the outlier. Early RRT showed benefit here, but it's a surgical single center, and it's contradicted by the AKIKI IDEAL-ICU and the STARRT-AKI trial. So let's go over the IDEAL-ICU trial, New England Journal of Medicine, 2018. Now we're looking at septic shock, rifle stage F AKI, multi-center, France, 488, stopped early for futility. The early RRT was 58%, delayed 54%. Early RRT had numerically worse 90-day mortality. The delayed, we're looking at 48 hours or absolute indication. And the early was within 12 hours. The DSMB stopped the IDEAL-ICU when the interim analysis confirmed no benefit. There was no secondary outcome benefit. The phenotype where you would most expect early RRT to help would be when you're on high-dose vasopressors, and it didn't show any benefit in that group as well. If early RRT doesn't help in septic shock with rifle F AKI and high-dose vasopressors, then who does it help? So there was no identifiable subgroup. Severity of illness does not override the evidence for watchful waiting. And so again, even in septic shock, severe AKI, the highest risk scenario, early RRT does not reduce mortality. IDEAL-ICU was stopped for futility. Don't let the illness severity override the evidence. Remember the evidence from the AKIKI trial, which was the French ICU trial, initially not showing benefit. This shows that even in the sickest patients, it did not benefit by doing early dialysis versus later. The STARRT-AKI we're talking a very large multi-center 2020 trial published again in the New England Journal of Medicine, severe AKI, 168 sites, 15 countries, the largest RRT timing randomized controlled trial, 90-day mortality. Accelerated RRT was within 12 hours. The standard was waiting for an absolute indication. Mortality is the same. The most neutral result possible was hazard ratio of 1. More than 1 in 3 patients who waited never needed dialysis, very similar to the findings in the AKIKI trial, but it's actually a little bit less. Every catheter you didn't place is a reduced risk. And then they looked at 600 pre-specified subgroups, and not one showed benefit for accelerated strategy. This is STARRT-AKI, basically is 3,019 patients over 15 countries. And power concerns limited AKIKI and IDEAL-ICU and the ELAIN. This is the most powerful trial. Absolutely no benefit from earlier RRT. And basically 38.3% of standard R patients never needed RRT. So watchful waiting is now the global standard. AKIKI 2 is Lancet 2021. How delayed is too delayed? 2 watchful waiting strategies. So watchful waiting has limit. Waiting beyond the standard thresholds increase mortality. So standard delayed is oliguria. Well, we could just do the AEIU acidosis, pH less than 7.15, potassium greater than 6, overload pulmonary edema, and uremia BUN greater than 112. Or would you do more delayed, only the true emergencies, which were potassium and pH and BUN? So those 3. And there was a higher mortality if you delayed just for only true emergencies. So 44% versus 55% mortality. Too much delay is harmful. So it is good to delay. But once you have any of those standard precautions, you should not wait until you really are stuck. So the sweet spot is oliguria, BUN, potassium, pH. So AKIKI and the STARRT-AKI say don't start early. AKIKI 2 says you shouldn't wait indefinitely. So there's start RRT when your standard thresholds are increased. Just think of AEIOU, not earlier, not later. Waiting beyond the standard thresholds increases mortality. So renal plus ATN is renal, New England Journal of Medicine 2009, ATN, New England Journal of Medicine 2008. Now we're looking at more ultrafiltration or more dialysis, and we'll see if it helps. So the first one is a Australia, New Zealand, Qatar, 1,500 patients, and the ATN was a multi-center U.S. trial, 1,000 patients basically. And the renal trial basically looked at high-dose CRRT, 40 cc's per kilogram per hour effluent, as opposed to the standard 25 cc's per kilogram per hour. The 90-day mortality was the same. There was more hypophosphatemia in the high dose, no difference in renal recovery. ATN a year before that, looking at 3 times a week intermittent or 35 cc's per kilogram per hour versus less intensive, which was 3 times a week or 20 cc's per kilogram per hour, basically did not show a mortality benefit. There was more electrolyte disturbances with the high intensity. So the CRRT effluent dose target greater than 25 cc's per kilogram per hour delivered the minimum IHD was 3 times a week. The overdosing adds hypophosphatemia, hypotension. So more RRT is not better. The 90-day mortality, 60-day mortality in both of these studies were not better. So your target should be 25 cc's per kilogram per hour, not 5 times a week IHD as in the intensive group, but just 3 times a week. And underdosing due to filter clotting is the real problem, not underprescribing. Case study number 7 is the FACTT trial. The fear that drawing patients out can cause AKI wasn't borne out. This was, we've seen this a few times in the other studies that we looked, other trials, other topics. 1,000 patients, conservative fluids versus liberal fluids. The liberal fluid had about 7-liter fluid difference at 7 days, but it did not increase your RRT need if you were dry. There was no increase in shock as well. So aggressive diuresis or fluid restriction will worsen renal perfusion, trigger AKI. That was the fear, but that was not realized. And conservative fluids in ARDS, better lungs, no kidney harm. But there was identical RRT use, so protecting the lungs will still, the kidneys will be fine. So that's Wiedemann et al., New England Journal of Medicine, 2006. Paper number 8 is the SMART trial, which we looked at in the fluids and pressors, but this is the 5 Vanderbilt ICUs, 15,000 patients, looking at MAKE 30, which was death, RRT, persistent renal dysfunction at 30 days, major adverse kidney events, balanced crystalloids versus normal saline. There was an improvement, reduction in the composite renal endpoint if you used balanced fluids, trends towards less RRT with balanced crystalloids. That was not statistically significant. The mechanism why normal saline would harm the kidneys. Normal saline has a chloride of 154 versus plasma, which is 102. So you can have hyperchloremia, you can get renal vasoconstriction because you get afferent arteriolar vasoconstriction, decreased GFR, and then acidosis, the strong ion difference decreases, and you get the non-anion gap metabolic acidosis, further renal injury. But the bottom line is balanced crystalloids reduce the MAKE 30 versus normal saline, and the mechanism is this hyperchloremic acidosis, which causes renal vasoconstriction. And overall, there is some benefit in using the balanced electrolyte solutions in terms of the renal replacement therapy. How about paper number 9 is the furosemide stress test. So how can you test the kidneys to see if they're likely not to recover? Cadigo, stage 1 to 2 AKI in the ICU. Basically, you give 1 to 1.5 milligram per kilogram IV of Lasix. You measure the urine output at 2 hours. If it's less than 200 cc's in 2 hours, high risk for dialysis. Area under the curve is 0.87. Greater than 200 cc's in 2 hours, lower risk, and there's adequate tubular reserved. It's not a tubular function test. It's not a diuretic. It's, it is a tubular function test, but it's not a diuretic. That's what the furosemide stress test does. It shows that you have tubular secretory capacity, and it's simple, cheap, it's actionable. So basically, you should know that number. Area under the curve, 0.87 for dialysis. It's better than biomarkers like NGAL, creatinine rise, and urine microscopy. So you could use that if you start seeing renal failure, KDIGO, stage 1 to 2 ICU. You give a little milligram per kilogram, 80 milligrams of Lasix, and then you see if there's output in the next 2 hours. Paper number 10 is the JACC cardiovascular imaging 2020 VEXUS trial. Post-cardiac surgery, we're looking at 145 patients, and basically there's stage 1, 2, and 3 here. This is the staging in terms of Cadigo, but VEXUS score, the venous congestion causing AKI, you have 3 Doppler patterns that were assessed: hepatic vein, biphasic or monophasic congestion, portal vein pulsatility fraction greater than 50% congestion, and intrarenal veins. And if your VEXUS grade was greater than 2, that predicted AKI within 24 hours. So Cadigo staging drives every trial. know the stages 1 to 3 because we've been discussing what the category was in terms of what trial inclusion. Like the last trial we just went over, the furosemide stress test was in category stage 1 and 2 patients. The VEXUS identifies congestive AKI, hazard ratio of 3.9. Venous hypertension from fluid overload causes AKI without hyperperfusion, and you would actually treat that with diuretics and not fluids. So that is a different type of patient population other than the classic ATN that we see in the shock patients. 4 more you should know: lung kidney crosstalk, mechanical ventilation, and AKI. More of a review of why it is that you will see oftentimes ARDS or lung injury, and then it's coincidentally found renal dysfunction because decreases venous return, decreases renal perfusion. AKI worsens lung injury via the inflammatory mediators, so it goes both ways. Protection trial, amino acids for cardiac surgery, AKI prevention. There was perioperative amino acid infusion, did show some decreased AKI, but no significant RRT or mortality benefit, but it is something that we might see further on. Hyperkalemia management framework, ICU emergency. Emergency sequence is how you would treat hyperkalemia: calcium, then insulin, sodium bicarbonate, and then the time to the dialysis after a life-threatening hyperkalemia is 1 to 4 hours. And then knowing the category AKI guidelines 2012, hyperkalemia refractory to medical management. So basically we went over the key trials: AKIKI, IDEAL-ICU, STARRT-AKI. They were negative trials for starting early dialysis. ELAIN trial was the single center that showed a benefit. AKIKI 2, basically don't wait too long. Renal and ATN shows that the standard dose and 3 times a week was okay. More is not necessarily better, and you might have more hypotension, hypophosphatemia. FACTT trial, conservative fluids did not damage the kidneys. SMART, maybe crystalloids are better in terms of the major adverse kidney events. Furosemide stress test, area under the curve, you should know. And then the VEXUS greater than 2, which is some neat Doppler testing, could be used to know when you should use diuretics for AKI. Thank you very much.